Have you ever had a plant start to wither on you and droop, and you're thinking, I wish I could make this plant come back to life and really thrive again. Maybe it needs more water. But then you think, well, how much water and how often? Do the leaves want to get wet or do I need to keep them dry? Or maybe it's not the watering at all. Maybe what you really need to be looking at is sunlight. Or maybe when you're not looking, your kitty cat is nibbling it. So there's a lot of things to consider. In our presentation today, the withering plant is the child or the teenager in front of you. And when you look at this patient, you're thinking to yourself, what can I do for this patient? Whether you're an athletic trainer or a teacher or a school guidance counselor, physician, a therapist, we all think to ourselves, wouldn't it be incredible if I could look at this withered child and know that I could help him or her return to thriving? I mean, for any of us, is there anything more frustrating than having a patient who just doesn't get better? Imagine how frustrating that must be for the patient and their family. And if we can't figure out what is going on with our patient and really determine what the best course of recovery is, that can be a very big problem. We do have a problem in concussion care right now. For a really long time, treatment for concussions was thought to be rest, mostly in a dark room with no noise, and parents were advised to let their children sleep for the first 24 hours. Not to let them sleep, keep waking them up. But unfortunately, right now, we are still in the past, presently. Many patients will come in wondering why this approach hasn't worked. And they come in very frustrated, upset, and even angry about what is going on, what can I do to help my child. And it's really kind of mind-blowing if you think of the amount of social media we have out there and you think about how we can be getting this message across. But we still need to work on it. We need to get this message out. Concussions are treatable. I can help you get better. You can have a full recovery. That's the most important thing we could be messaging to our patients. Imagine looking at that parent with their withering child and really knowing that this is the turning point. You are about to restore hope and show them the path to recovery. And that's what we're going to be talking about today. Our goal for this discussion is for every one of you who have taken the time to be here to start knowing that that moment in your office is the turning point for this patient, right there. And in fact, something interesting is that even now in this time where we are resorting a lot to telehealth, I've found that we're still able to assess and we're still able to provide some treatment for our patients so that even though they may not be able to be in front of us, which of course would be much better, we still can make a difference. We can all have a tremendous impact on the recovery process. We can work together to change the course from one of prolonged symptoms like headaches and dizziness and exhaustion to an organized and efficient and effective approach that will start to reduce symptoms immediately. Want to know how? I can't wait to tell you. Let's start with a typical patient presentation that I see in my clinic. A 17-year-old soccer player who gets hit during a game, and her coach says, "Are you okay?" And she says, "Yeah," because that's what kids say when they're in the middle of the game. And maybe she doesn't realize that she's really hurt, and maybe she's not feeling that hurt until she gets home after the game. And then as the adrenaline starts to wear off, and as the adrenaline from her playing, the adrenaline from her friends, as that all starts to wear off, then she starts to feel like something's not right. Maybe she tells her mom, maybe she doesn't. But the next morning, when she wakes up, she realizes she has a really bad headache. And she starts to make the connection with the night before when it gets worse and worse. Maybe she starts vomiting, and maybe she's starting to get dizzy. Now it's time to call the pediatrician. And the pediatrician may refer the patient and the mother to the emergency room. We need to be aware of what the red flags are for a serious injury. And I know this is a busy slide, but these are available to us on many websites and in a lot of publications. The red flags are something that are really well distributed. So these are taken from the CDC website. And for all of us, we would recognize neurologic change, which is really what we're looking for, and whether or not that's something that's more of an emergency room. One pupil being larger than the other, drowsiness, inability to wake up, the headache that keeps getting worse, the slurred speech, numbness, vomiting that won't stop, seizures, obviously, convulsions, that agitation, a loss of consciousness can never be underestimated. And sometimes we wonder with the younger set, the infants and toddlers, how will we be able to tell? And a giveaway with them is if the infant won't nurse, or the toddler's refusing to eat, or if they really just are inconsolable with their crying. So she goes to the ER, this patient, and she has a concussion. So what's she told? She's told, go home and rest for a few days. If you're still feeling badly, call your doctor. Okay, great. By the time she gets to my clinic, it's been 2 weeks. Symptoms are fluctuating, but they're not improving. There seems to be no rhyme or reason. Sometimes she can manage school, sometimes she can't. At this point, the teachers don't know what to think. Guidance is completely baffled. Parents and the student, let's call her Sally, they can't figure out how to manage with these academic pressures and the persistent headache and dizziness that she's dealing with. She's always been such a good student. She's taking 3 APs. She has a driving test in 6 weeks, and the SATs are coming up. There is total despair. That's what I would call it anyway. In so many cases, when I meet them, the families are really in despair. And I'm willing to bet many of you are familiar with that despair. It's when we see something and we just really want to ease it. We're problem solvers. So what are we going to do to solve this problem? It starts with building confidence. Our first task is really to build the patient's confidence, first in their ability to heal and recover, and also in their confidence as us being the ones who can facilitate that recovery. Before we get started on testing our patient, which is definitely going to be provocative of symptoms, we really need to build rapport and trust through sharing and understanding and providing normalization and practical educational points for them. As you listen to the patient tell you what the main concerns are, you can gradually explain that this is normal to the presentation and what the expected functional recovery will look like. Often, high school students, especially those that are involved in sports, will have taken baseline tests. You have to make sure to ask about this. Sometimes they don't even remember that they've done it. Baseline testing usually consists of at least a neurocognitive computerized test to get an idea of how the student does in multiple domains prior to any injury. The idea is that although tests like IMPACT have norms that even take into consideration ADHD or history of migraines or the amount that the patient has slept, it's still not going to be exactly the same as that individual's score prior to injury. So when we do a post-injury test, it's a lot better for us if we can compare that child to himself and see how we're doing with recovery, with the recovery process. The testing becomes even more robust when they add in a balance screen and maybe some visual screening as well. But getting back to the computer test, we also need to just check in with the patient because often the school setting is not ideal for the testing. As in this picture, the students are sometimes piled on top of each other, and that can mitigate the seriousness of the testing that they're doing. Students are usually pretty honest about the fact of whether or not they gave it a real effort or if they just took the test and it's not a good example. And that's going to make a difference in how you look at that baseline test. In clinic, the first test that I start with is the patient symptom survey. There's a few examples on your screen right now. In the middle, that's the standardized assessment of concussion taken straight off the SCAT, the Sports Concussion Assessment Tool, which is often used as sidelines, but you can feel free to use this for your symptom evaluation as well. You'll also notice that there's a parent report on that one. Many times, this is the child SCAT-5, many times the pediatric assessments will ask parents as well, especially for the under 8 to 12-year-old set. But I find even the teenagers, honestly, when they're giving scores, will sometimes refer to their parents. Is that actually a 4? I don't know. Or their parents will make faces while they're giving you their answers. So you usually get parent input whether you've asked for it or not. On the left is the acute concussion evaluation. And on the right, you have the graded symptom checklist. I usually use the post-concussion symptom survey. And they all go through many, many surveys, sometimes around 30-something questions. And this is not just good for us, but it's also really educational for the patient and their family. Because when they learn that there's such a variety of symptoms associated with the concussion, sometimes that's an aha moment for them, where they really say, wow, this is affecting me in these ways. I didn't realize that was from my concussion. For the provider, for us, it helps us start to unravel the process of what are we going to be looking at? What is the most important thing right now? Symptoms are going to fall into multiple domains. So you have cognitive, emotional, which includes mood and anxiety, cervical involvement, vestibular and oculomotor involvement, exertion intolerance, which can indicate autonomic dysregulation, sleep disruption, and headache, among others. So now, instead of a blanket treatment of rest, 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 we can actually start to tailor our treatment to the individual patient, first by just listening to them and figuring out what domains are involved. Here's why this is a diagnosis that involves an interdisciplinary team, right? So we really need to get everyone involved, because if my patient in the physical therapy evaluation is presenting with terrible anxiety, which isn't uncommon if the symptoms have been lasting for a long time, whether that's a week or whether that's a few months. If my patient has anxiety and feelings of depression, I need to think about getting counseling in place. Often a patient will report memory or cognitive executive function deficits, and that would lead to a referral to neuropsychology. The neuropsychologists play a critical role in helping our patients and in providing screening and testing for them that can really help the whole team have a better understanding of the patient profile. Many schools appreciate the neuropsychologist being involved to speak to the academic portion. Here's the thing, we know people are complex and very multifaceted, so a brain injury is also going to be complicated. If we can take a team approach, then we can help the patient in all the areas that are affected, especially if we can be doing that simultaneously. We can change the course of recovery tremendously. We just need to develop our teams. In the school setting, that's going to be the development of a strong concussion management program with liaisons to work with medical professionals and the families. In the medical center, it's a team who work together, whether or not they're in the same physical location, to communicate about the patient's needs and their presentation. Unless you have that ideal setting of a concussion program with neurology, psychology, neuropsychology, physical and occupational therapy, speech and cognitive therapy, and a school liaison, which most of us don't, it can be a challenge to find your team. I want to encourage all of us to make sure that that does happen. We have to work together, because we can't expect that plant to grow with sunlight but in the absence of water, or with the cat still nibbling at it. All the areas of care must be treated if we want to get full recovery. It's really not that uncommon for me to see a patient's progress in physical therapy be really limited by too much anxiety or exhaustion from trying to keep up with an unrealistic academic schedule. So in that initial meeting with the patient and family, we can start treatment right away, immediately, by providing encouragement and education. Some of the things that I strongly recommend teaching right away is explain what the concussion is. Even if the patient and parent understand that it's a hit to the body or head that results in trauma to the brain, resulting in neurologic changes, it might not be something they understand functionally. So I'll often compare it to a cell phone and say, the same way that you look at your cell phone and you need two things more than anything else. You need power and you need connectivity. And right now, after a concussion, those things are down. Right now, you can't get a full battery charge. That's why you're so tired. And right now, your connectivity is down. And that's why things are working slower for you. This is an opportunity to really normalize the feelings that they're having, which is a huge relief to many patients and their families. Or these kids are walking around with an invisible injury, and all their well-meaning family and friends are saying, "Oh, are you okay? You look great today." So when we normalize it and say, it's okay that you're not okay, I know you're not okay, I can see that, really helping them. We also want to educate about an expectation of full recovery. This is really important, and so much so that it's even mentioned in the new clinical practice guidelines from the APTA, that we literally need to be messaging our patients, all of us, consistently. You will recover. We expect you to recover. You should feel better. With our pediatric patients, we also need to be mindful of telling them that the length of recovery time is longer than it is in an adult. So that means that the under 21 set has a more rapidly developing brain than after that. And so their energy is being diverted more than an adult's. So for an adult, 10 to 14 days is considered spontaneous recovery. But as it says in the guidelines, you know, for kids, it can take 5 to 6 weeks and still be considered within spontaneous recovery. That also can bring a tremendous sigh of relief from families that are 3 weeks out to hear that this isn't unusual, this is still fine. We need to educate our patients about brain rest. So here's where I end up giving a little bit of a neuroanatomy lesson, even to patients and their families. I explain how different parts of the brain physically are responsible for different activities, so that if we want to rest the brain, what we need to do is switch activities. Teaching them this and teaching them how to take breaks can be tremendously powerful for them. We need to educate them about the gradual return to activity. So we talk about return to learn, but Dr. Jerry Joya, he says it's not return to learn, it's return to academics. We need to consider how much more is involved in returning to school life than just returning to the academic portion. Sorry, he says returning to school life. I think I just misquoted. And that's really important because you think about a high school setting and the time in the hallways and going to your locker and getting to class on time and dealing with a teacher that you think doesn't like you and getting to the lunchroom. There's so much more going on at school than just the academic piece. So we really have to be mindful of that return to school. We also have to communicate about return to play, which can't take place until the student is already back in school with no more accommodations. But the return to play is something that's more publicized. Even on the recreational teams, we do a stepwise progression where each step is followed by a 24-hour waiting period to confirm that this has not caused symptoms. So for physical activity, we look at that when a patient is coming out of physical therapy, they're usually in the middle of this progression, and we return them to their athletic trainer and their coaches to do the rest. We need to educate our patients about symptom management. Usually we use a 2-point symptom scale. And this is important because we have to walk a fine line between hyper-focusing on symptoms, which is shown to make them worse, versus just kind of monitoring how we're feeling. So I use an analogy of a toddler that if you've ever babysat or had a younger sibling, when they're a toddler and they're just doing their thing, you kind of leave them alone. But if they ask you for something, if a toddler asks you for a drink of water, best bet is to get them that drink of water right away before they start to ramp up and really press you for that drink of water and getting very upset and crying. And that's the way it is with symptoms. They're not going to let you miss them. If you have a symptom that's getting worse, you'll know. And you just need to address it right away. So we need to be mindful of the symptoms without focusing on them. And that's something that takes a while to explain. Based on that, patients can start to pace and plan accordingly. They can see what activities are bothering them more and plan to do them for shorter periods with breaks built in. We need to teach our patients relaxation techniques. We have wonderful apps available to us. This is just 2 examples. And we need to remind them to hydrate. Tons of water is very helpful. Make sure they're eating 3 meals a day. We often talk about adding breakfast back in to a busy teenager's life, and sleep hygiene. Sleep is a big issue after concussion. In the acute period right after the injury, we have a crazy metabolic cascade from the diffuse axonal injury, or DAI, that's occurring. It causes an energy crisis because the cells are trying to regain homeostasis in an environment where cerebral blood flow is likely altered. So for the first day or 2, there's a very good reason to slow down and let your child rest as much as they need. However, after that, we need to move to the idea of relative rest and activities within symptom tolerance. The big key word or phrase is active rehab. That is so important. Research is showing us that inactivity prolongs recovery. Movement is medicine. We are finding more and more that physical activity of all kinds can really promote recovery. So patients get confused about rest and brain rest. They think that rest is the most important thing and that they should do this and not do anything else. Until I feel better, I shouldn't move. And what ends up happening is athletes get deconditioned. Secondary things like neck soreness is going to intensify. Anxiety and depression increase. Sleep disruptions escalate. Concentration gets harder and harder, and the headaches worsen. I recently had an experience of an 11-year-old girl coming in to see me. And she couldn't get from the waiting room to the treatment room without holding on to her mother. Her balance was so poor. She had the unfortunate experience of having to wait 2 or 3 months to get in for physical therapy because of funding issues. But when she first presented, no one advised her to do exercise and to just at least go for a walk. So with her neck pain being bad, she self-splinted and she stopped moving it, which only made it worse. And then she stopped moving her head altogether and only moved with her body, which had implications for her vestibular system. So now her balance was completely off. If only she had been told right away that she should just at least take a walk around the block for 20 minutes a day, she might not have had that severe presentation later. With all the recent research activity in this area of treatment, we as professionals helping patients with concussions are in a position to formulate a plan of care to really intervene effectively, individualizing our treatments to each of our patients. The physical therapy evaluation is going to include a cervical spine assessment. And it's important to realize that even though all these things are listed on this evaluation, these are all things that need to be assessed. But just as our new clinical practice guidelines point out, we do need to adjust based on levels of irritability. So if somebody has a terrible situation in their neck, then you may not be doing your vestibular testing on the same day. If you don't have a separate appointment for their ortho and a separate for vestibular where they can rest in between and recover, it might be too much for them to do all that on the same day. Or maybe it's too much to test their exertion intolerance in the same day. So we really all have to kind of take our patient, do as much as we can, determine, is there going to be a physical therapy need? And then if there is, we can always do more testing as we go through treatment, as opposed to front loading everything and really overwhelming our patient. I think it's also really important to notice that in the new clinical practice guidelines that really were just published last month, they have beautiful flow charts, and they have a flow chart that says how to determine if your patient needs physical therapy, and a flow chart of saying once they're in physical therapy, how do you determine what areas to treat, and even one for referrals. So I would definitely recommend taking a look at that. But as we look into our cervical spine, these are the things we're going to be testing. If the patient hasn't come from neurology and hasn't come from the ER, then we definitely need to start with our special tests to rule out instability. We check range of motion, we do strength testing, endurance testing, palpation for areas of tenderness in the cervical and thoracic spine, joint mobility tests, and JPE testing, joint position error. So up until JPE testing, I think at least the PTs in the room know all of what I'm talking about. So let's just talk a little bit about the JPE testing. So this is a picture taken from YouTube, the Physio channel, and you can look this up. It's a really nice little clip of doing the JPE testing. And this is basically going to give you information about cervical proprioception. So the patient is going to wear this laser on their forehead and literally look at the target, center it, and then close their eyes, turn away, and try to bring it back to center without using vision. So that's where we're getting this idea of the proprioception. And it's quite interesting to see sometimes it's just to one side and then the other they're good. And this becomes a rehab technique to really work on this proprioception piece. So getting back to our patient, Sally, she didn't feel specifically any neck pain. But when we did palpate, she discovered, yeah, that is tender. And then we were able to do some massage, and boy, was she surprised when that relieved symptoms of her headache dramatically. So it's really important to know that patients, when you ask them about neck pain, may say, no, my neck's fine. But then when you actually do the assessment, you discover something. So we really want to make sure to get our hands on our patients and touch their necks. Okay, that's super important. The next thing we're going to look at is, by the way, I am seeing the questions loading up. I'm just going to wait till the end. But we're going to do our balance assessments next. And we do a static test and dynamic. There are times where we need our balance to be there for us when we're standing still, and there are times when we're moving, obviously, that we need our balance to be there for us. So we look at both. We always want to assess both. For us, for our static testing, if you're lucky enough to have fabulous funding in your clinic, you might have a dynamic posturography that is computerized. And this is a fantastic setting where you can harness your patient up, and you have a movable foot plate where you can induce little perturbations. You can make the visual mismatch and anything else that you could possibly do to a patient standing still. And it feeds amazing information, but it is quite expensive. So for those of us who don't have access, it is perfectly fine to use tests such as the modified CATSIB and the balance error scoring system. And what you're seeing here is the modified CATSIB. You're going to choose between these two tests based on your patient. Again, if you have a kid who's coming in who is not athletic and even maybe was described as clumsy first, then you're probably going to stick with modified CATSIB. Whereas if you have an athlete who's been playing sports his whole life and plans to be professional, you would probably go with the balance error scoring system. And I'll explain why. So for the modified CATSIB, we have 4 conditions. Our patient stands with the feet together, arms held like you see across the chest, and they do each condition twice with their eyes open and then their eyes closed for 30 seconds. So in the first picture, she has her eyes open, then she has them closed. Notice that we're always standing close to our patients when we do a balance test. It sounds simple, but it's easy to forget, and try and do this from across the room. Never a good idea. You always want to be close by. So you time each of these for 30 seconds. And on the CAT-SIB, the patient has 3 tries to get to 30 seconds for each condition. And if they step or they have a huge sway and they have to recover their balance, that's where we stop time, up to 3 tries. The balance error scoring system is a little different. The positions are feet together, single leg stance, and tandem, and we do that on the floor and then on foam. And for that one, it's 20 seconds per trial. And we ask the patient to continue to try in that position for the 20 seconds, regardless if they lose their balance, but we count the errors. And there are norms for that as well, based on gender and age. For our dynamic testing, typically we rely on the dynamic gait index or the functional gait assessment, which is really more appropriate for this population. The dynamic gait index is a little too easy for most of our teenagers. Maybe we can kind of modify it and use that for younger kids. And then there's also the HIMAT, which is even a higher level than the functional gait assessment and includes things like skipping and leaping forward. So here's just one little example from the functional gait assessment with our patient. And again, you want to stand close to your patient while you're doing this test. And this is the head turn assessment. So this one looks at walking with head turns, walking with vertical head turns, walking backward, walking without vision, walking with eyes closed. Even this, if you have the right patient who's a real athlete, there can be a ceiling effect. So you need to be mindful of that. And this is a standardized assessment. You want to do that to get your score. But if a kid is getting 30 out of 30 and you know this kid has some balance issues and they're feeling off balance, then maybe go off paper and start doing some of your own. So they want, let's say, 10 tandem steps. You might want to do 20 tandem steps and then see if they can do tandem backward, and then try tandem with eyes closed, and then try tandem backward with eyes closed. These are high school athletes, so we expect them to be able to do more. And we do want to check on that and see how it makes them feel. Also, even though the testing is just looking at deviation from the path, as a clinician who's looking at this, you want to know, how did those head turns make you feel? So in our case with this patient, she did not feel terrific with head turns and with eyes closed. The next thing we're going to look at is vestibular and oculomotor screening. If I am able to go through all these assessments in one shot, I'm still going to leave my vestibular and oculomotor for last, because this is a really provocative area. So now we could really set our patients off into a lot of symptoms. I might even finish my education points instead of wrapping up at the end with what I want you to do. I might even talk to the family about it here before I start this and just say, I just want to go over so far. Also, really important to give your patient rests during the evaluation. Even though it is provocative, taking a minute to give them a glass of water, let them breathe for 2 minutes. And that also gives us the opportunity right in the session to maybe practice a 2-minute breathing technique and show them, I know your symptoms are ramping up. Let me show you how to bring them down. And I find that to be very powerful, because once the patient starts to get comfortable with you, they might be more comfortable saying, I don't do that, I can't do that. In this evaluation, you sort of have their attention a little more. They're just getting to know you. They're starting to trust you. And you can teach them this relaxation and practice it with them. It can be very helpful. And again, they leave with a tool to start feeling better immediately. So basically what we're doing with the vestibular and oculomotor is that we always want to look at vision, because it's representing of so much in our brain. And we can't do vestibular testing without knowing that our oculomotor has already been screened, since that can really mess up our results. So we're always going to look at this. And just to note, there are tests even that are being used on the sidelines that are vision screens that are even somewhat diagnostic of concussion on the sidelines. So vision is a tremendous thing for us to use. For the screening for our concussion patients, you don't have to feel that you have to be a vestibular trained therapist in order to do the screening. The folks out of Pittsburgh who did the impact test also came up with the VOMS, the vestibular oculomotor screen. And this test can be done by any of us, and it is almost diagnostic and certainly a wonderful screen and a great baseline to get that you can compare to for outcome. This test consists of these items, and you basically start by getting your own baseline in that moment. You say to the patient, how are you feeling? 0 out of 10 for headache, dizziness, nausea, and foggy. And then you're going to go through and test each of these. So I'm just going to show you videos for these. Here's the smooth pursuits. Okay, so you're going to sit about 3 feet in front of your patient, advise them not to move their head, keep your finger moving at a pace that is normal for them, and then ask them, how do you feel? How did that affect you? Any increase in symptoms? You're also watching them to see what you think. And you're going to do that also with vertical smooth pursuits. And unfortunately, I don't have video of the saccades, but the saccades are the same motion, and you're going to put your hands, your fingers out and say, holding your head still, please move your eyes back and forth between my fingers as fast as you can 10 times. And the back and forth counts as 1. And you have the patient look back and forth 10 times. You can count for them as fast as they can. And here again, you're looking not just for, did they do it? What was the quality? Saccades are the fastest movement in our body. You shouldn't see them doing this slowly. This should be very quick, very accurate. Are you seeing that quality? That's very important to notice. The other thing to be aware of is a ceiling effect. Again, the patient might feel fine doing 10 saccades, but this VOMS is for any age, all the way up to 65 years old. Maybe our high school students need a little more pushing. So again, you can kind of go off paper for this a little bit and ask them to do 30 reps. And you may see a very, very big difference when you get to 20. And these, again, these are people who are reading. We need them to have very strong oculomotor skills. Convergence, this is one that patients really don't love. They're going to bring a small 14-point font X towards the bridge of their nose. I advise the patient that it will get blurry and then it will split. So I really show them it's really going to split as it comes towards you. Please wait. And again, you are watching for quality. You're watching their eyes. Did their eyes converge? Did you see lateral excursion as it came closer? And if they converge, you need to know the distance. How far away from them was the target when they saw the convergence happen? It needs to be within 6 centimeters or that's convergence insufficiency. We do this 3 times and I have to tell you, patients do not like that one. That is a really bad one. Now that's the end of the vision screen portion of our VOMS. Now we're moving into the vestibular portion. And this one, you're going to want to take out your phone, or if you have an actual metronome, you want to use a metronome because you want the patient turning their head at a specific speed and looking again at that 14-point font target. And they're going to turn their head 10 times and let you know how they feel. So as soon as they finish, you say, how are you feeling? And you're going to do that horizontal, and you're also going to do it for vertical. I think it's really important here also to show your patients the head movement. So we don't want to see this crazy moving, or we'll end up with a cervical problem we might not have even had before, or like crazy shaking. That's not what it has to be. A small movement, I tell them, like shaking your head no, or nodding your head yes. And interestingly, by the time I say nodding your head, they're nodding at me. Okay, yeah, I got it. And I say that's what I want you to do. Just a small movement will stimulate the semicircular canals. We don't need a huge neck irritating movement. So that's an important thing to educate our patients about. And the last condition that we do on the VOMS is visual motion sensitivity. This is also VOR cancellation. So let's just talk about the VOR for 1 minute before we continue. Here's a little thing for you to do. So let's take our thumbs. Everybody just put your thumb in front of you. And I want you to move it back and forth as fast as you can in front of your eyes. And it should look pretty blurry because when you're moving your thumb really fast, your visual system, when you're holding your head still, your visual system cannot keep up. It doesn't have the capacity to keep that thumb stabilized on your eyes. Now try the same thing holding your thumb still and turn your head super fast. And you'll be amused to find that your thumb is very much still stable. It's still very clear for you to see. That's what gaze stability is. And that's the vestibular ocular reflex. That is the cornerstone of vestibular rehab. We work so much with this reflex and we need gaze stability in order to navigate our environment. So when we do visual motion sensitivity, this test that we're doing, we're actually turning off the VOR. We're actually saying, instead of compensating and helping me, I want you to stick with this target, okay? So we put the patient's thumbs in front of them. They're focusing on their thumbs. This time you want a busy background. You do not want a plain blank wall. You want to get that visual motion, so you need things. The place she's facing looks similar to the place that's behind us. So she's got a nice busy environment to be looking at, and we're going to ask her to turn, again, at a specific speed. And she's focusing herself, and see how I'm close, because again, this is not specifically a balance test, but I will tell you 9 times out of 10, this is the worst one for your patient. They come off this, that's it, they're done. So you want to be close by, because a really significantly impaired kid could fall over at that point. So you need to be very careful. So for us, for our patient, we see that she had difficulty with saccades. Saccades were slow, and that is really interesting, because even though she didn't have dizziness, she fatigued after those 10 reps. And we know that reading is repeated saccadic movements. So now we're starting to really get a picture of what's going on with this patient, right? Because isn't she going to have fluctuating success in school if some days there's a lot of reading and concentration, which is her weak point, and then some days, well, maybe it's not such intense reading, so she has a better day. So this is so fascinating, because it's so easy for practitioners that are so well-meaning to mistake a complaint of dizziness with thinking vertigo, or maybe just a little Dramamine for a while. Maybe the reports of headaches with reading are misinterpreted as just fatigue, and that as she gets more rested, she'll just feel better with it, and totally miss the fact that there's an oculomotor deficit going on that needs the rehab. So you start to really see how amazingly different we're going to be working with these patients when we do a careful assessment, so that we can really, really target our treatment and decrease the recovery time. Just to mention also, as a follow-up in clinic, if we do have a patient who has a lot of vestibular concerns, we're probably going to do some more specific vestibular testing. This is the dynamic visual acuity test, and we also do the head impulse test. And the dynamic visual acuity, the example I'm giving you here, you have a Snellen chart up on the wall, like you see on the right. The patient first looks and reads to whatever line they can. Again, you don't want a ceiling effect. They should be limited at some line. You're not trying to measure acuity for glasses. You're just getting an idea of static visual acuity, not moving the head. And then you get to do this for them. Go behind them and move their head very quickly to try and assess how much they can do while their head is moving. I know it looks horrible, but it's pretty amazing, because most patients with concussions don't have any problem with this. So that's an interesting thing to note. But if you did have a patient who had real vestibular involvement, this is one of the tests that would be done. BPPV, benign paroxysmal positional vertigo, is not something we see frequently with pediatrics in general. But of course, when someone's been in a trauma that's giving them a concussion, it's possible that they also have some BPPV issues. So if you hear your patient complaining about the room spinning when they sit up from bed, or when they bend down to tie their shoes and they come back up and everything is spinning, that's definitely an indication to check for BPPV. Some people will do this routinely. Certainly it's something that you do want to check if you're not seeing progress and you're getting concerned that maybe you missed something. If you haven't done it, then you would go back and just do a quick Dix-Hallpike and a roll test. And again, if you're not comfortable with these things, you can always refer to a vestibular therapist. Finally, we need to assess exertion tolerance, which also informs us about potential presence of autonomic dysregulation. We want to look at orthostatic hypotension, which gives the patients a feeling of lightheadedness and is often described as dizziness, and will occur with position changes, especially getting up too quickly. So this is another differential for us to be thinking about when our patient complains of dizziness with movement. There's so many different areas that can cause that dizziness with movement. So this is one more. Again, in our new clinical practice guidelines, it does talk about the responsibility of the physical therapist to check for this. And you basically are going to do this by measuring blood pressure at rest, either in supine or sitting, and then change the position and measure again. Basically looking for a drop in blood pressure. And this is kind of funny, because they'll tell you a drop in blood pressure, 20 systolic or 10 diastolic, but then really the test is, do they get lightheaded or dizzy when they change their position, and how fast is that happening? Doctors John Letty and Barry Willard developed a treadmill test, the Buffalo Concussion Treadmill Test, which was based on the Balke protocol used in cardiology stress tests. This has really become a huge cornerstone of concussion care. And Dr. Letty is really promoting the concept of movement as medicine based on his findings. The way this test works is that you put the patient on the treadmill at a consistent speed around 3.5, and the patient starts walking. Before they start, again, you're going to get that baseline of how's your head, headache, nausea, dizzy, foggy, what are you feeling now? What you're looking for is that as you're increasing the exertion, is the patient having a change in their response, in their symptoms? So if they started out with a 4 headache, if they get to a 6, that's where you're going to stop the test. You're just looking for that kind of 2-point significant increase in symptoms. So every minute that the patient is on the treadmill, we increase the grade by 1%. We ask them for the rate of perceived exertion. How hard are you working right now? And we fill out what's their heart rate, what's their RPE, and if symptoms have changed at all. This allows us to dose their aerobic activity. So we're able to give them a way to do their activity using a heart rate monitor to keep it to a place where it will be safe for them and help them continue to progress. We're also going to provide strengthening exercises, but we do avoid resistance training until the aerobic is cleared. Okay, so this is really the key to the movement piece and the way we can very safely and gradually return our patients to their prior level of cardio fitness and exercise. So finally, we're going to need to really consider the results of our evaluation, make our plan of care, including those appropriate referrals. You've got a really good idea at this point about your patient. You see what's going on, and you see the things that are outside your scope of practice. Again, whatever your practice is, if you're neuropsych and you see that maybe this patient's having some balance issues, you want to refer for PT. If you're PT and you see your patient is really not seeming to manage well in school, maybe reach out to that school liaison, try and coordinate with the school team. So we're looking for this interdisciplinary approach, of course. So, just thinking about it, kids and teens have such a hard time being unable to participate in their regular ADLs. And it does take a while to get them on board with this whole concept of pacing and planning and pulling back, especially since for some reason, most of our patients end up being these really driven academic students or athletes. It's not usually a personality that likes to pull back. So this can really be a learning curve for them and for their families, and it can take a while. And through our treatment sessions with patients, especially physical therapists, where we really get to spend a considerable amount of time with the patients on a regular basis, while we're doing treatments, providing rest breaks, telling them, okay, grab a drink. Okay, we're going to just do some relaxation for a minute, bring you back down, and then we're going to try this activity. Showing them that we switch activities. So maybe we're doing oculomotor exercises, then we do some cardio, then we go back to maybe some vestibular. So we're not working the eyes. We switch from an eye activity to a cardio activity, maybe a coordination thing. So when we do that, and we do it with breaks and with relaxation intervals and really teach that, we're also modeling for them how they can do with their life. And it really becomes that dance of 2 steps forward, 1 step back, 2 steps forward, 1 step back. And that's hard for any of us, but especially for kids. Kids are not known for their amazing patience, and we have to really encourage them and keep them feeling good about it. And as they progress, it really does, the speed does pick up, and then they start to feel encouraged, and we get encouraged because it's so much fun for us to observe, right? It's really an exciting time to be part of the team of people who treat concussions, and really to work with all of you. And we can really improve our patients' outcomes. We just need to start simplifying recovery and giving our patients consistent messaging. Okay, it's active rehab. Movement is medicine. If nothing else, tell the patient they should try to move as much as they can tolerate within their symptom tolerance. And even if it's just a stroll around the block for 20 minutes, just do what you can. Don't stop moving. And also, it's a team approach. Don't go it alone. Remember, there are many disciplines involved, and by working together, we can make our biggest impact on our patients' recoveries. So before I end and look at questions, I just want to say that we just take a moment to acknowledge all our friends and colleagues who are so affected by COVID right now, and really want to just do a major shout out to the Brain Injury Alliance for making it possible for us all to be together today, to have this time together to learn, even though we had to switch to a live webinar, and they did that so well. I also just want to not let today go by without mentioning Joanna Boyd, who brought me into the concussion team here at the Brain Injury Alliance, and has been such a leader in the Brain Injury Alliance and in the concussion part of it especially. And we miss her very much, and we will not forget her. So thank you all for coming today. Let's work together to make sure that our patients and our plans continue to thrive. Feel free to contact me. Like I said, I'm happy to share my references with you and answer any questions and give you links to any of the tests.
Okay, so I am happy to read the questions. So the first question is, are there any baseline tests for elementary and middle school students?
That's a great question. Impact actually does have a specifically pediatric impact now that is for the younger kids. And also, again, that SCAT5 is a really great tool. It's a paper and pencil tool, and you can use that. The Child SCAT5 is a fantastic thing to use. And there will probably be another one. The consensus for sport-related concussion group meets every 2 years, and they will be meeting in 2020, I hope, if everything goes well. And they usually put out a new version of the SCAT. So we'll be looking for the SCAT6 in the fall.
Thank you. Next question. I recognize there are research studies on young males and females regarding concussion. Can you speak on the other gender differences in concussion among youth in terms of incidence and outcome?
Okay, so if I understand the question, there are a lot of comparisons between the boys and girls. Oftentimes that's attributed to girls being more willing to report their injuries. Oftentimes it's attributed to difference in neck strength, that the boys are thought to have stronger necks, which helps them resist the injury more. I think it's also interesting to note that we don't tend to see tons of toddlers coming in for concussion rehab. And I don't have this from the literature, but just anecdotally, it seems that toddlers kind of know what to do. They know how to rest and pace themselves. They have no problem just stopping an activity, and nobody's pressuring them with SATs. So they're usually able to kind of relax as needed. And I think that helps tremendously with their recovery. I'm not sure if that answered the question.
Yes, thank you. We actually have a couple of questions from the chat room. The first one is, how do you prescribe an exercise program for your active rehab?
Okay, so that's a great question. First of all, let's just talk about active rehab. It's not just the exercise. And I'm glad you mentioned that, because an important point is that when we talked about the acute rest period, that first 12 to 24 hours, maybe 48 hours where that metabolic cascade is taking place. So that's a really important time to just rest. But the active rehab, even without going to physical therapy, even without it being a prescribed program, starts right then. As soon as the patient can tolerate it, we want them up and moving. And I feel like this is should be in a commercial, because 2 days after injury, parents should start taking these kids out for a walk, even if it has to be super slow, even if they have to wear sunglasses. They need to just start moving within their tolerance. And so that means getting up and doing things. As far as academics, it means maybe trying to read a paragraph or a page and see how you're feeling. So active rehab means doing what you do within symptom tolerance, taking breaks, but trying to do. So, for example, I was out in Arizona at a concussion conference and got a call from my sister-in-law in Baltimore that her daughter had a concussion. And I'm sitting there at the conference texting saying, if she's feeling better on day 3, we need to get her back into class, take her in, even if it's just for an hour. I want to see kids going back to school if they can tolerate it. If it's severe though, then maybe we're going to have them at home and trying a little bit of homework first. Dr. Joya talks about if you can have 30 minutes of school activity at home, that might be an indication they're ready to go back for a class or 2. So that's a gentle way to look at it. But the active rehab part isn't always a specific exercise dosage. In the clinic, when we talk about it, we're definitely talking about the cardio piece, and we like to do the treadmill test first to assess exactly a heart rate. But even if you can't, you just say, walk for 20 minutes, not with the dog who's going to stop every 2 seconds. We're talking about continuous walk for 20 minutes within your symptom tolerance. And that's a start.
Thank you. Next question. Is there any guidance as to the level of activity patients should aim for? What is too much or too little? Is there a time limit or specific activities?
Great question. So again, this would tap right into the pacing and planning. So basically what you want to do is you want to see how that activity is affecting you. So you try an activity and you literally can set a timer. Sometimes I'll say, try to do your homework tonight. When you're reading history, set a timer. As soon as you start to feel a little bit worse, if symptoms start to come in, see how much time that was. Was it 10 minutes? Was it 20 minutes? Now, when you go back to it, take a break, go back to it, try doing it for 15 minutes. If it was at 18 minutes that you started to not feel well, and take a break. So again, it's like this idea of every activity is on the table. In fact, I really enjoy when I get to be a hero and give kids back their cell phones. You know, parents will be like, I'm not letting them play on the cell phone, no tech. And I get to go, oh, you know what? You totally can. Let's see how it affects you. But you need to be honest. So here's where also we need to get this buy-in from our patients that they're going to listen to what we're saying. If you work with me, I'm going to give you back your cell phone and your Snapchat. But if you go and binge on Netflix for 8 hours tomorrow and you're in a world of pain after that, you overdid it. And now, you know, actually you've probably prolonged your recovery because you've just complicated it. Your brain was trying to send you a message saying, I can't take it. You're killing me here. And you ignored it. So you've kind of prolonged it. You made it a little worse, though the damage is not worse. The recovery process just got longer. And that's something I'll mention and say. So again, it's not a specific activity right away. And those you kind of learn in clinic. So again, if you're dealing with an athlete, you're going to want to think more sports specific, especially, you know, the guys who are playing football certainly want this to be appropriate to my football game, getting back to my game. They don't want to be doing too much of that sitting and meditating, let's say, or running. That's not necessarily their forte. They'd really rather do other things. So we really need to look at each patient and find the thing that they're going to enjoy.
Thank you. Next question. What are your thoughts on iatrogenic effects as it relates to persistent concussion symptoms?
I need that clarified. Any ideas, Jenna?
I'm not entirely familiar with that.
I mean, I think that we need to just be aware that, again, we need to be really messaging positivity and recovery to our patients, and we all need to be doing that. And if one of us on the team is like, no, yeah, you really aren't doing too well, that's not a good idea.
Thank you. Next question. How do you address students and parents who are anxious to get back to sports ahead of what is recommended?
That's a great question also. So sometimes we do have to become a little bit dramatic about the fact that your child only has one brain, and that, you know, we're hoping for other things in life besides finishing out the soccer season. And that although it may be hard to imagine your 10-year-old in college right now, you probably have started your savings account. So that is something you're thinking about. And this is his brain, and it's not going to do any good if we hurt his brain because he's in a soccer season. So it's really important to emphasize that by not listening to these guidelines. And you can usually say, like, look, what you've been doing isn't working. That's why you're here. So I need you to kind of buy into my program and work with me, and we will get you back to it, but we need to get you back safely, and we need to make sure that you're not going to have a more lasting injury. So one of the things that I message to the patients is that if you don't pay attention to your symptoms and you don't manage them, you are prolonging your recovery. So instead of making it shorter, you're actually going to make it worse.
Thank you. So this is a multi-part question. You had said that an individual has to return to academic normalcy before return to play. Can you speak more on this? I feel like this is a rarely followed aspect of protocols.
I hate to hear that part. Yeah, so it's really a hard and fast rule. And this is, again, where we get that buy-in from our athletes, is that you are not even remotely returning to play until you are able to manage full school days with no accommodations in place. So when we start our students back to school, this also, by the way, gets rid of all that problem of malingering, the kids taking advantage, because they're not getting back to sports until we don't have to have any of those accommodations in place. So that's really important. You know, they're so happy when we take out our checklist and we start saying, you can't handle tests right now, right? Okay. And you need extra time for homework, right? Yes. Okay. And blah, blah, blah. And we're checking all these things. That makes them very happy because they're like, wow, my school day's been so miserable. Now maybe it can be better. But none of those things can still be in place if you want to start playing sports. So that's what we mean, that all the academic accommodations have to be gone. You have to be doing well in school, symptom-free, managing your days, and then we will continue with return to play. I just want to note, though, they are also doing their return to play protocol in physical therapy. So the first 3 steps of that let's say 5 or 6 stepwise progression are being done in PT. And you can explain that to them because they know they're not feeling well in those sessions. They're not coming in and feeling terrific. They're coming in and you're challenging them and showing them, and they feel off, and then they go home and they practice and they get better at it. So they're seeing their progress with the physical therapist. They are going to understand, you're right, I'm not ready to play. I mean, if I can't handle visual motion, how am I running down a field trying to get the soccer ball while keeping track of the other players? It's just not possible. I'm going to fall. God forbid I could get another injury.
Thank you. Next question. During this COVID period, when you were doing telehealth treatment, obviously you are limited with your ability to evaluate as you would in the clinic. Can you speak to the modifications that you have made in your PT evaluation tools?
Yes. Was not easy. It definitely required some practice as someone who had not done it previously. But it really is an amazing thing that you can do. You can really do the VOMs. Obviously, you're going to want to take into account that you're doing it over a computer, but it's amazing when you know your screen, how you can like come here and have the patient track your finger. You get to know what to advise patients. I'll have a patient print a little target for themselves for convergence. I'll have a patient have space to do walking. I'll ask them to have an area ready. So my first tip is definitely send a checklist ahead of time of everything the patient has to have prepared, because otherwise you're going to catch them on their cell phone, like in their backyard with no idea that they were going to be doing anything specific. So you want to have a couple of things ready. They can take a pillow off their couch. They need to have a family member standing by. Then you can do the modified cat sit. You just watch them from the computer. So it is hard. You're not going to be able to do a true functional gait assessment, but you can get a really good idea. And I have not figured out how to do the treadmill test via telehealth. We'll have to ask Dr. Letty about that. But in the meantime, what I have advised patients is to just start walking, just start doing some movement that's not provoking symptoms. I need you to start moving. And then if we need to, we can always do the treadmill test and have them come in and right now do masks and social distancing.
Thank you. Next question. How do you feel premorbid psychological factors contribute to persistent concussion symptoms?
Tremendously. That is a really, really hard one. I did get a referral recently, and the patient has a history of cutting and a history of a lot of psych issues. And it is an excellent question because it is really complicated with that. It's hard to know. So I think that in those cases, we have to be very clear again on what our role is. My role is to be the physical therapist on the team, not the neuropsych, not the psychologist. I need to make sure that I'm not trying to fill someone else's shoes. But I think also that PTs tend to be really good for patients because we see them multiple times, because we have all of us this nature of great job, you're doing great, look at that, now you're doing that. We're able to modify things. Our expertise is in taking an activity, pulling it back to where our patient is, and then going slowly forward again. And that's so motivating and empowering. So it is complicated and it is much harder. But I think that if we just kind of keep our eye on what our role is and be very careful with that, we can manage.
Thank you. Next question. Typically, how soon after injury are you seeing acute concussion in your clinic?
It really varies. It's a good question. There are people, especially socially, people who know what I do, and they'll call me first before they call anyone else. Oh, what should I do? And that's, again, why we all need to know our red flags. But typically, I would say that I get most of my referrals from the neurology group, and so they're sending people to me who seem like they're just not a simple headache. They have more involved, and they want me to take a closer look. So I would say on average 2 or 3 weeks after injury, and then unfortunately sometimes many months later.
Thank you. Next question. Can you offer any future directions regarding having the current neuroimaging findings, for example, brain structural and functional abnormalities observed in TBI patients relative to healthy controls, effectively applied to the current clinical diagnosis, interventions, and/or treatment associated with cognitive behavioral deficits following TBI?
I feel like this person who's asking this question really is giving me a very big ego boost to think I would know that. Thank you so much. That's a really complicated question, but I kind of understand where you're coming from. There's a big hunt on right now for the diagnostic blood test or imaging that could be used. And Dr. Letty recently was saying that he thinks his treadmill test is really very diagnostic, and that alone can tell you if someone is concussed or recovered. So I think there are so many people looking at this from so many different angles. I find it kind of fascinating that with the diffuse axonal injury, that's where you have this release of the tau proteins amongst other molecules that are picked up on the blood tests. And about 2 years ago, there was a New York Times, almost headline saying, we have the concussion test. And it wasn't. It was just a marker of like, oh, this might be a good idea to put this kid through a CAT scan. So it was more a marker for imaging than yes or no concussion. But I think that there are studies going on right now where they're looking at levels in the bloodstream and seeing, do we see a difference as the person's recovering? So I'm not a researcher and I can't really speak to what we would do, but I think that is something that is being worked on right now.
Thank you. Next question. When speaking to new patients, do you ever give a typical time frame for resolution of symptoms? If so, how long?
That's a great question. Yeah, I would say everyone asks that question. How much longer till I feel better? So this is also, you can be a little bit manipulative here and be like, well, if you adhere to the exercise program, it certainly will be sooner than later. And that's usually going to be my answer because there's no way to know. I think we know more as we start to work with the patient. And that does have to do with their compliance level. I mean, if they're not doing anything at home, the recovery isn't going to happen. So we're seeing how they're doing in terms of compliance, but then also how they're responding to therapy. And it is different person to person. Some people respond more quickly than others. And also sometimes it's on us. Maybe we didn't figure it out right. Maybe we thought we had it figured out and that we just had to work on this one area and it was all going to get better. And then it just didn't. And we have to really rethink and kind of reassess and see where we are in terms of our treatment to make sure that we're accurate with what we're doing. So the answer, is no. I can't give a time.
Thank you. Just to let you know, we do have 10 minutes left in our talk today. So we have time for a few more questions. The next question is, due to the number of concussions in sports that don't wear headgear, such as girls lacrosse, how would you suggest people take caution to that? My daughter did have a concussion during high school lacrosse.
Gotcha. Yeah, that's when I watch lacrosse, I am completely fascinated by what the athletes are doing in that game, just from a vestibular standpoint. It's mind-blowing. It's interesting you ask about that because a lot of the conversation with the football helmets goes back to the original game all the way back in the beginning of football when all they wore were little leather like hats, not even real helmets. And what they found is that the players did not smack into each other as hard. So that's why in some of the youth football clubs now, they're actually doing no helmets and they're taking helmets off for practice so that kids don't hit each other as hard. And I think that that's an interesting thing to be aware of. The helmets, and this is well known to some of us and not known at all to others, the helmets don't prevent concussion. It's something that's taking place inside the skull. So they're working, again, as fast and furiously as they're looking for the blood test. They're also looking for the helmet that's going to prevent concussion. And it's really fascinating. They actually just had an article in a Consumer Reports recently that was comparing different types of helmet technology that's working on the rotational component that can take place so that maybe it can absorb some of that impact to lessen the degree that goes on inside the head. But it is really something to be mindful of, that it's not the helmet and the gear. It's really the play and the players. So it's a tough one because childhood obesity is way more of a problem right now than concussion, even though concussions are so serious. But we don't want to have all of our kids sitting on the couch doing nothing. We want them playing sports. We want them active. So we really have to be careful taking them out of sports. When do we do that? And how are we going to be able to make sports safer and still have them enjoy it? And I think that's really something that the clubs are all working on now. And everyone is becoming more aware of concussion, thank God. And so they're trying to make it a game that's safer. Probabilities are that the lacrosse coach is working also on neck strengthening because they do feel that if the person is aware of the hit before the hit happens, meaning sometimes you're blindsided, sometimes you see it coming. So the when you see it coming moment, if your neck is a bit stronger, your reaction time's a little better, you might be able to avoid a concussion.
Thank you. Next question. Actually, it's a two-part question. Does your treatment plan change depending on the number of previous concussions? And also, have you ever recommended retiring from sports due to multiple concussions?
Gotcha. Okay. So I think knowing about multiple concussions it tells us a lot. One of the things it's telling us is this is a flag for prolonged recovery, because do we know, did the patient fully recover from those concussions prior to this one? So chances are that the patient did not fully recover because this one got them in. So it's likely that they still had a little residual imbalance, maybe a little dizziness at times, or a headache that lessened but didn't completely go away, and now they got injured again and everything's much, much worse. So unfortunately, that does complicate recovery in the sense that it probably will take longer. But call me an eternal optimist, but I would say that I still expect full recovery from that. I still think that we can get to that point. It's possible we can't. It's possible they're going to have lingering effects. Again, that's why it's so important to have a team, because although I may want to be that eternal optimist, I may need the neuropsych to say, not happening. This person has significant change at this point, and we're at the place where we are. I think that that's when people start talking about retiring from play, and that's not something I would ever take on myself. That's something I would give information to the physician and have the physician make the determination. But in my opinion, it's a very, very serious thing to do. I'm very alarmed if someone tells me their 14 or 15-year-old was retired from play, and I'm very curious as to why that took place. Was it from multiple concussions? What I've heard many experts talk about is recovery time from concussion, and also susceptibility. So meaning if the patient gets a hit, the first concussion they ever had was from a soccer ball at point blank range getting bashed into their head, that's a totally understandable concussion. When someone throws a little Hershey miniature at the same kid's head and that causes a concussion, that's when someone's going to start talking about retirement. Like, we're not in a good place. If you can have your threshold is just too high, it's no good. So, that's, I think, a lot of the considerations, but it really has to be done with tremendous caution by someone who's very confident in their expertise as a concussion carer before they do something like that to a young child.
Thank you. We have 5 minutes remaining in our talk today. Next question. Are there any new sports or activities you're seeing more concussions come from lately, aside from the football and the typical ones we see?
Not particularly, although in passing, the neurologist I work with in the hall, she was saying probably going to see a lot more trampoline incidents with the fact that COVID has happened and people are just desperate to try and get their kids outside, and that seems to be something everyone's doing. A lot of trampolines right now. So, and it is kind of interesting right now that as we are all sort of quarantined, we aren't seeing as many patients come in. So it definitely does increase with increased activity level, but not specifically anything novel, no.
Thank you. Next question. Should you try both cognitive and physical activities starting no later than day 3 post-injury and control dependent on symptomology?
I would say yes, with a lot of caution and a lot of attention to that symptom management. But yes, I would be starting activities in both of those domains.
Okay, just to let attendees know, this presentation will be available for future viewing and future reference. And as you can see, Danette Macklin has left her contact information on the final slide if you do have further questions. We have 4 minutes for some additional questions. Next question. Can you address some strategies for returning to school or work after concussion?
Sure. I think that I really like Jerry Joya's work. I think that the idea of doing some schoolwork at home for, let's say, up to 30 minutes, and once someone can tolerate 30 minutes, then starting to go into school. And since this is a pediatric presentation, I'm going to stick to that. But basically what you're looking for is, in my opinion, first have the child go into their favorite class, and just their favorite class. Even if it's math, which math and science are usually those really cognitively intense ones that are typical to produce symptoms. But if math is their favorite, or English, have them go in just for that class and then come back out. And I do acknowledge that this puts a burden on the family. I know it's hard for you to take your kid just for one class, but this is a brain injury. And that's, it's a lot better to be dealing with this inconvenience than the inconvenience of going to the hospital for a traumatic brain injury. That was a lot worse. So, we're dealing with a brain injury. It is going to take some time. Very gradual immersion into school, then start just going for short amounts of time. very important to work with guidance, the school nurse, the faculty, the teachers have to know what's going on. They're going to see a child walking in the hall, laughing and kidding around with their friends who looks just fine, and then comes into their class and halfway through class is saying, I need a break, my head's killing me. And the teachers sometimes think the kid is making it up. They're like, what? I saw you in the hall. You're fine. Now you're just doing this because you don't want to do your work. They don't realize that it's the cognitive load and that there was a relaxation and a depression of those symptoms while in the hall with my friends feeling good and not focusing hard on subject matter and reading and maybe looking at a smart board. So it's that communication piece that's just so incredibly important. And then just taking it slow and really respecting the symptom response.
Thank you. We have 3 minutes left. Final question. Can you speak about the challenges students and families face working with teachers to customize academic classes? Any tips to engage educators in the rehab process?
Definitely. I think I just kind of answered that one already, but I would like to make you aware that the Brain Injury Alliance does have a concussion committee full of volunteers who have committed themselves to working on this. And this is something we talk about all the time, and we talk about it on our Concussion Awareness Day programs, how much we want to work and partner with the schools. So what you can suggest to your school is to contact the Brain Injury Alliance and see if one of us will come out and give a quick talk on concussion. Most of us are happy to do that if we can, if it's in our geographic area, and we can just educate the faculty. I've had high schools call me in at the beginning of school when they're doing their orientation days for the teachers. I go in, give a talk for 20 minutes even, and it makes a huge difference. When I see teachers in the hall later that year, they'll say, oh, I remember you gave that talk, thanks so much. We just need them to really get educated, and that's going to require more collaboration between medical and educational systems. So again, the Brain Injury Alliance is really working on this, and it's something that we're going to continue to push and try and get that education out there.
Well, thank you very much, Danit, for a wonderful talk. This concludes our workshop.